Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. I'm delighted to be joined today by Lisa McCarthy. Lisa is a pharmacist and associate professor within the University of Toronto in Canada. So Lisa will be our first international guest. Aren't we lucky, eh? She's also a Learning Health System Fellow with Trillium Health Partners, which is one of Canada's largest hospitals. She has more than 20 years of practice experience across acute, primary and ambulatory care settings. And it's her research that we're going to talk about today, really. In particular, her research interest around deprescribing, the people, processes and resources needed to optimize care models, and also talking about prescribing cascades as well. Lisa and I first met at a congress which has been run by the European Association of Hospital Pharmacists. I think it was in Lisbon, Lisa.
We were in Vienna, I think.
It was Vienna. Thank you
See,
for
I'm
that. It
giving
was
you a hard
Vienna.
time. Yeah, just COVID days, right?
It was just after COVID, yeah. So we were very lucky to be invited to the president's dinner. And on the president's dinner, you had to go downstairs to the bathroom, and you had to use an elevator, a lift, to go down to the bathroom. And Lisa and I got stuck in the lift together. So as a result of that, we then became friends and colleagues and have done some work together. And I've invited her as a guest on the podcast to talk, as I say, about deprescribing, what it is, and the importance of deprescribing networks internationally, and the work that they've done in Canada. It would be remiss of me at this stage not to mention the excellent resources that we produce here at PrescQIPP to support deprescribing and person-centered medication review, in particular the impact tool. So this impact stands for medicines and polypharmacy appropriateness clinical tool. I'll put a link in the show notes to that, and also the other excellent deprescribing resources that we have. Lisa is also very keen for me to say that she has a personal time governed by Ozzie, who is a schnauzer poodle rescue. So again, we bonded on the fact that we both have dogs, and we've both got children. She's got 3 teenage children as well. That also occupies your time, Lisa, doesn't it?
A little bit.
just a little bit. So, welcome, Lisa. How lovely to see you. Thanks for joining us.
I'm so excited to be here. I'm really honored to be one of your first international guests. Thank you for the opportunity, and definitely I will try and minimize my Canadianisms, but you can call me out as we go through.
Fantastic. So just tell me a little bit more about your career journey so far, and the highlights, if you like, of your career so far.
I would say that I'm going to start by owning that I'm another pharmacist on your podcast with what you guys have called a squiggly career. And my path has probably largely been driven by curiosity, like a lot of us, right? So as a pharmacist in my heart, most of what I kind of do from my research and my clinical life has been kind of underpinned by wanting to make sure that people get the medicines that they need, no less and no more than that. You kind of talked about my scientist life already, and that I'm really interested in thinking through how do we bring evidence to reality, the best evidence that we have at the time, and developing care models in partnership with people that they're intended to serve. Like a lot of people, I don't think I grew up wanting to be a pharmacist. I did have the opportunity to work in a community pharmacy through high school, and I kind of thought about that as a career, but I ended up in pharmacy for a few reasons. I'm one of the first people in my family to go to university, and I started in this liberal arts degree, and I needed some more focus after a couple of years. And I decided I wanted a career where I could combine my interest in science and my desire to work with people. And so that's kind of how pharmacy kind of came forward for me. After I did my undergrad pharmacy, I had the opportunity to do what's called an ambulatory care residency here in Canada. And it really confirmed for me kind of the key ingredients about practice that made me really excited. So at the time, those practices where we had access to the most information about people. Things have gotten a lot better in community pharmacy since that time, but at the time you didn't have very much. You were working in a vacuum a lot of the time. I really love forming longitudinal relationships with people, and I loved being able to see what happened when we made best plans, and then kind of see how they unfolded for people. So those are kind of the ingredients that excited me. And in order to do that work, kind of going forward, at the time you needed advanced practice training, and so I went back to school. I have a lot of going back to school stories. And I went back to school to do a post-baccalaureate PharmD. And after that training, I had the opportunity. I actually thought during my PharmD studies, I was going to be a specialist, right? This is where we saw value in our profession. Let's get really deep and specialize in a particular area. And then when I went to go and find a position, I had the chance to be one of the first pharmacists that was integrated into kind of what we call family practice, or akin to kind of your GP pharmacist role. And that was really my like top rewarding clinical job actually ever, and where I really kind of thought about the appeal of generalism. And so for me, that position let me kind of think about, like, it exposed me to the power of quality improvement, to teaching evidence-based clinical practice. That led me to go back and do a master's degree. And my story has kind of unfolded from there. So my rest of my practice life has been around, I get excited when I get to create new practices, and I've done that several times in different places, and I've done that within hospitals and community settings, that kind of stuff. And then about 2 years ago, I got really interested in kind of the power of quality improvement and teaching evidence-based practice, and that led me to go back and do a master's in ClinEpi. And I would say that one of the things that's excited me then about my practice since then has been the opportunity to kind of develop new practices in different areas. So I've done a lot in terms of internal medicine and ambulatory care settings and geriatrics. And I spent most of the rest of the last 10 years of my career kind of as a scientist embedded in hospitals doing pharmacist practice as part of my role. About 2 years ago, not quite now, I actually transitioned over though to the University of Toronto to a full-time faculty role. So definitely never saw myself as a full-time faculty member at a university, and here we are.
So do you still see patients now, Lisa, or is it largely academic, your career now?
I would say I have been on a break from my patient care for the last 18 months. I miss it. After 20 years of not doing it, but I have been exploring all kinds of things in terms of academic administration, and so there's only so many hours in the day, right?
Sure, absolutely. So just in terms of for our, because most of our listenership are UK based, just could you just describe kind of the Canadian healthcare landscape and how pharmacists fit in with that?
I think there's actually a lot of similarities between our countries, and the more that we talk, I think there's more that unites us than divides us in terms of how we're different. One of the key differences, I guess, to understand about the Canadian health system is people talk a lot about, in contrast to the American system, that we have this universal healthcare system. In Canada, what universal healthcare means is that you have unrestricted access to physicians and to like emergency like hospital services. We don't actually have uniform coverage for things like medicines or for paramedical services like physiotherapy and those kinds of things. So we are structured differently than the NHS, for example, in the UK, and that we have a hodgepodge of how people actually can access medicines through our country, which creates a whole bunch of challenges when you're trying to work on optimizing the medicines that people receive.
Yeah, and the other big difference, I think, and we've had lots of conversations about this, is that obviously we have independent prescribing by pharmacists here in the UK. I think you have pockets of that in Canada. Am I right? And I know there's a movement to get pharmacists prescribing, but so how's that working?
Yeah, so we have 10 provinces and several territories in our country, and we do not have a harmonized scope of pharmacist practice across the country. So in every region, it's slightly different in terms of what pharmacists can do. The leader in the space of independent prescribing has really been the province of Alberta, where for 15, almost 20 years, they've had independent prescribing. Most provinces have some form of it now in terms of it started a lot with being able to renew and adapt prescriptions. Most provinces also now have like a common ailments or a minor ailments prescribing scheme. And then even back 20 years ago when I was doing my family practice, we had medical directives and we were prescribing that way. So there's lots of different models that exist across our country. One of the things I know our national advocacy body is really working hard on is how do we harmonize our scope of practice across the country.
Yeah, I mean that's very much how it worked in the UK 20, 25 years ago. And then there was that move to, as you say, harmonize it, almost legitimize what pharmacists were doing, which was prescribing and then getting the physicians to countersign the prescription. Whereas actually having that independent practitioner role and being an independent prescriber, I think most people would say has revolutionized the way that the pharmacy profession has headed in the UK, and I hope that's the case in Canada as well. I really
I
do.
think it's really coming. There's so many exciting things actually that are happening. When I think about like the role of what a pharmacist was when I trained versus the students that I'm training now for the roles that like what we know they can already do like within their scope and what we anticipate they'll be able to do, it's amazing. And what an exciting time to be a pharmacist, really.
So I mentioned at the start, didn't I, that one of the shared interests that we have is in deprescribing or medication appropriateness, as I think you guys call it now, which I'm quite pleased about because I'm one of those people who doesn't really like the term deprescribing. It feels a bit negative, but medication appropriateness is much better because it feels more, I don't know, consensual and person centered. Just talk us through why you have a particular interest in that area.
So for me, so it's funny because I've got two thoughts that came to my mind as you were talking about this. One is around like the terminology and how we all still have not landed on the perfect terms. I think we know what we're trying to get to, which is people taking, what they need, no less and no more. The terms of what we call it is a whole soup. I'll be
Yeah.
honest with you. I am a reluctant adopter of the term deprescribing as well. And you can hear that, like one of my hats is I'm a co-director of deprescribing.org, right? So how can she say that? And yet, like really, it's about deprescribing is part of good prescribing, right? It's we start medicines, we monitor and we manage them throughout their journey. And at times we have to reduce or stop. And so if you think about it as this continuum, it makes sense that we're thinking about it, but we don't spend a lot of time talking about how to stop or reduce. And so that's really how I kind of got like from a conceptual perspective, why I'm interested in stopping or reducing. We just don't spend as much time there. My own story about how I got to be involved in deprescribing, it's funny. I'm probably going to age myself again. You will, you and I are similar vintage, right? So you'll remember the Women's Health Initiative trial back in 2002. And that was around the time I was doing some residency training. And I actually was working in a menopause clinic at the time. And so a lot of my time during that residency experience was around doing deprescribing with people that were taking hormone replacement therapy. We didn't call it that at the time. And we certainly, it helped me realize how much we didn't know about how to stop or reduce medicines for people and how much of an individual plan you needed to create. So the importance of shared decision making in those conversations. And so that from there, I was always interested in thinking about how do we stop or reduce. And from there, I went into work in the family practice and I was encountering tons of examples where people were going to be better served by stopping than they were by continuing medicine. And so I was doing it at a practice level. And then I had the opportunity to meet Barbara Farrow, who is the founder of deprescribing.org. And we realized that we had this shared interest, and she was founding kind of the work of deprescribing.org at the time and let me kindly join as a co-investigator on that journey. And so kind of the rest is history in terms of that piece.
So that was your journey into the world of medication appropriateness and deprescribing. It's an interesting one, isn't it? Talking about sort of management of menopause and HRT and the WHI study. It's funny how these things come full circle, isn't it? And now we're working with women to make sure that if they want HRT and because the evidence has
There are
moved
so
now.
many examples in my career.
Absolutely,
I talk with the students that I
absolutely.
teach now about really being just when I talk about new drugs, I'm probably on the diffusion of innovation curve, probably more of a laggard. In terms of, I'm definitely not an early adopter of new drugs, and I think you and I are aligned
Yes.
on that one. But also, absolutely, lots of stories about how evidence shifts over time. I mean, I think you and I have talked in the past about, um, and this isn't necessarily evidence, but the story of OxyContin and oxycodone and what's happened over time in terms of how we manage opioid therapy, and that being another classic example where like what we were taught at one point has completely shifted. And you need to be able to embrace that as a pharmacist, which can be hard to do, right?
Yeah, absolutely. I mean, the therapeutic areas that I know that the Canadian network have done lots of work on are things like opiates, benzodiazepines, and hypnotics, appropriate medication for hypertension, and deep prescribing for hypertension as appropriate as well. I mean, listeners will remember the series we did with Lucy Pollock, the geriatrician, talking about appropriate deprescribing in our precious elderly people. And things change as you get older, and priorities change. But what doesn't change is the fact that you need to make the person the centre of that conversation and find out what really matters to them at that point in time. So for somebody who's in pain and requires something like oxycodone, that it might be a completely appropriate thing to do at that point in time. But then these things
It's
change, and we
100%
have to
aligned.
change
Yeah.
with that, don't we? Absolutely, absolutely. So just in terms of the de-prescribing networks as well, then. So obviously there's the Canadian network. We did have an English de-prescribing network here that was started by two of the clinical fellows, called Eden, so the English De-prescribing Network. I think that's gone a little bit cold at the moment, but I know there are moves to try and get that network back up and running. So just in terms of international collaborations and what goes on in Canada, what de-prescribing networks are there?
So for us in Canada, so I am one of the executive members of we call ourselves now the Canadian Medication Appropriateness and De-prescribing Network. We were founded back, so we changed our name. We were the Canadian De-prescribing Network. We broadened our name, recognizing that de-prescribing is part of optimizing or the appropriate use of medicines, whatever term you want to use, and to broaden our mandate somewhat in order to be able to attract some resources. We were founded in 2015. The Australians actually started their work a little bit before us. So they had the Australian De-prescribing Network. And we were kind of together, kind of some of the leaders internationally, I think, in this space. The US has the US De-prescribing Research Network. They were founded back in 2019 and are really focused on how do we move research forward in the de-prescribing space. So both the Australian group and the Canadian group have quite broad mandates in terms of public outreach, healthcare professional education, as well as research. The US network is focused primarily on research, although that extends into those things because you do research about how to educate people. And there's also the network of European researchers in de-prescribing. So they call themselves NERD for short. And they formed back in 2019.
Yeah, I love that. Love that nerd because I'm a nerd myself.
I know they're awesome, right? And so those are kind of the key networks. But I will tell you that there are while Eden, it was funny. I was over. I had the opportunity to visit England back in 2018, I think, around the time that they were trying to start this work, and share some of the learnings that we had from Caden. And there is absolutely, you guys have such a core body of people that are so committed to this work. And so I really think it's really exciting now that there's some renewed interest in how do we move this forward. And I think you guys have done phenomenal work too. Like I think about the NHS polypharmacy action learning sets as a huge example of like something that like has moved the country forward, even if it's not under the label necessarily of a de-prescribing network. Like that's huge momentum that you guys have created. So I think there's also an English presence in the international networks, I would say. So for example, we have Sean Scott, who is helping us to plan like a next international conference on de-prescribing. There's all the work of Debbie Bhattacharya. There's lots of people in the country that are doing the great work. And then internationally, there's core pockets of people in Ireland, in France, and Germany. Even Iceland now is looking at forming networks. So it's such an exciting time to think about what's happening.
Yeah, fantastic. What we'll do is I'll put some links in the show notes to the Canadian site, and also you've also got the international collaboration on de-prescribing as well, haven't you? ICORD. And I think, am I right in saying you have a conference every year or every 2 years for that?
We are aiming for every 2-ish years. So there have been there was the first one was the International Conference on De-prescribing, and that was held in Denmark. We convened again in France not that long ago, and we're lucky actually to be convening in Montreal, Canada, in April of 2026 for our third ICOD. As the conferences kind of evolve in terms of what they do, we are really hoping to reach out to kind of new audiences and bring more international presence. And there's lots of exciting things happening. So I can tell you more about ICOD, but that's just one of the ways actually that these networks work together. So that one will be co-hosted by the Canadians and the Americans for ICOD 3. But we have all been working together in terms of there's an international journal club on deprescribing that is held every quarter that lots of organizations are involved in and send speakers to. Anybody's able to attend that if they wish. You just sign up for the newsletter of one of the organizations and then you'll hear about it, because we all work together to kind of promote and share each other's messages across too and promote events. We also do a lot of collaboration on kind of research and scientific output. So there's lots of ways that these networks are now starting to work together, which is really exciting.
Fantastic. So for anybody listening who thinks, first of all, how do I make links internationally? There you go. And also, if I want to get involved in research in this area, what do I do? So again, we'll put the links in the show notes for people so they can get in touch with people like yourself on that. So
awesome.
Yeah, thanks for that, Lisa. So just in terms of deprescribing guidelines then, because we get asked a lot about, I remember when I was working at NICE, we did a guideline on multimorbidity, and I talked about this with Andy Hutchinson a couple of weeks ago, actually, about that sort of, can you write a guideline how we manage people who have got type 2 diabetes, hypertension, osteoarthritis, and depression? Well, no, you can't write a guideline on that because it's about the core principles of that. So deprescribing similar, isn't it? There's not a lot of evidence from randomized controlled trials that says if we safely stop this medicine in this person, this is the outcome. So you have to work in a much more, principles of care-based approach to practice, don't you? So what deprescribing guidelines are there then, Lisa?
Well, so there are certainly some, and they're growing. I would say that you're right in that navigating kind of deprescribing for a person really is where like you have to take the science and apply the art to how are we going to actually do this, for an individual person based on what matters most to them and what the evidence tells us is part of the story. And you're right, there are real gaps in terms of the evidence that we need to move forward to really understand, how to reduce or stop medicine safely. It's interesting because we have in the deprescribing evidence world, we talk about there's a certain standard for starting medicines, and then people are holding us to a particular standard for reducing or stopping medicines, and you wonder whether or not like all of this request about the paucity of evidence actually makes sense, because sometimes it's the right thing to do to try to stop. But in terms of the actual deprescribing guidelines, part of my answer to your question depends on what you mean by a guideline. And I know you'll know this really well from your work with NICE, and that there is absolutely a ton of like consensus-based guidance that's existing now in terms of deprescribing. And I think a lot of that has its place, particularly when we have gaps in the paucity of evidence in particular areas. At deprescribing.org, we try and apply well-known methods for developing clinical practice guidelines to the deprescribing scenario. So that means using methods that are developed by like the GRADE Consortium, which really looks at how do we assess the quality of evidence that does exist and determine the strength of the recommendations that we can make about deprescribing. So we have a very like rigorous process that we follow. And we have created alone or in partnership with different teams. We have kind of 5 core clinical practice guidelines that we've created, but we have a number that are actually ongoing. And one of the things that the listeners may not know about is actually we have on our deprescribing.org website, forgive the plug, something called Depot. And that is our deprescribing, it's a deprescribing guidelines repository. And really what it is an opportunity for people that are working in this space of developing guidelines or guidance to register what they're working on. And what we're really hoping for, it's public facing, and everybody that registers, you can register an in-process guideline or one that's done. If it is complete, we do an agree to, which is a way of assessing kind of guideline quality rating on it. And let that be there for everyone. And that's a great place where people can go and find out about our guidelines at deprescribing.org, but also other ones we've collaborated on. So for example, our Australian colleagues have led ones around opioids, which is not kind of part of our deprescribing.org suite, but we were involved in it, as well as they're working on one about gabapentinoids right now. There's a group working on one about diuretics. There's antidepressants. So there's a lot that's being developed actually using kind of really good methods, and people can access on Depot. And if somebody's working on one and they want the rest of the world to know about it, let us know and we'll help you promote it, because we really want to enhance international collaborations, bring forward like the best possible methods on developing these guidelines, and like streamline our efforts. Like let's not duplicate the wheel, right? Or like reinvent the wheel.
Yeah, I think that's a really good point. So the areas you've mentioned there, like gabapentinoids and opioids and antidepressants, funnily enough, they're the same sort of target priority areas in the UK as they are in Canada, as they are in Australia, as they are in the Nordic countries.
Absolutely.
The other, so why would you then duplicate the effort and as you say, reinvent the wheel when it's already there? That collaboration thing is so important here. It really is, because as you say, Lisa, there isn't the evidence from large randomized control trials to do this, but what there is a strength of, I don't know, brotherhood and sisterhood on this with the different networks. I've done this. We've done this. We've written a guideline around best practice on this. This is okay to do that. One of the big themes that came out of the polypharmacy work was prescribers' confidence in stopping medicine safely. And people feel quite reluctant because they don't have the confidence to do that. But talking to other people who've done it gives you that confidence to do that in a safe way. And I think that's what comes across loudly from all of this for me. It's that sort of sense of we're all in this together. We can all support each other. We can help each other.
Well, I 100%. I also think that like when I work with individual practitioners, I try and encourage people to frame things as like, let's do an experiment. Let's see what happens. Let's try reducing or stopping and pick what we're monitoring for and following it over time. And so that's one of the things about deprescribing that is so important and sometimes gets lost. It's not just about stopping without talking to your patient. It's about actually making a plan together and about deciding what you're going to follow forward in time and seeing if it works. And even if we have to go back on the medication or we have to increase the dose, you know what? You've still been successful because your monitoring worked.
Exactly.
And I think that's such a key message that I know that you'll really kind of relate to in terms of like people's comfort with that. Like it's okay to not feel 100% certain about what we're doing, but we're going to do it together.
And I know the other area that you're interested in is the kind of prescribing cascades. And we talked about this lots with Lucy. So prescribing cascade, I think the example that Lucy gives is somebody's got osteoarthritis, they're prescribed naproxen. It increases their blood pressure by 5 millimeters of mercury. Therefore, they're prescribed amlodipine. They then get ankle edema from the amlodipine, so they're prescribed furosemide. They then get incontinence of the bladder, so they're prescribed oxybutynin, which is and the problems that ensue from being
on and so on.
Yes. So those prescribing cascades, I know that's a real area of interest for you as well, isn't it?
Yeah, I've been privileged to be involved in teams that we've been studying for this for about a decade, and prescribing cascades are so much fun, but they are messy in terms of practice. So we often, particularly for learners, and I remember listening, like I did have the chance to listen to Lucy's sharing the story of Mrs. Alexander, and that case is masterful for learners. What I would say is in the real world, the challenge, of course, is that sometimes we end up with even more complexity in terms of prescribing cascades. Like, for example, if you have, two medications that could lead to the same side effect, what do you do then? How do you figure out which one is, causing the cascade or causing the initial that led to the cascade? So there's lots of different messiness in that, but we have also had challenges around needing to really land on what actually the definition of a cascade is. In terms of being able to study it further, we need to kind of come to an international consensus on what a cascade definition is. There was an original definition that was advanced that a lot of people know about, which is, a medicine leads to a side effect that's misinterpreted as a new medical condition, and you receive a medicine to treat it. The challenge with that definition is it doesn't actually necessarily capture all of the situations in which somebody uses a medicine to treat another medicine side effect. So this is getting kind of academic-y, but I'm involved in work kind of looking at how do we conceptualize cascades. We've done a lot of studies about understanding why and how they occur in different practice settings, as well as, lots of epidemiological studies about like how often are they actually happening and how do we describe that. Where I'm actually really more excited now is looking at how do we develop interventions to manage prescribing cascades, both of preventing them, which is where we're seeing like an abundance of kind of consensus-based lists coming now. I've created them. I've been involved in creating them, and they're helpful. But for me, it's also teaching people about how do we identify them, investigate them, because they're messy to manage, like messy to figure out, and then how do we manage them by deprescribing. So that's kind of my where we're going in terms of prescribing cascades. But it's so exciting. There's been like an explosion in terms of the number of people that are interested in this topic and that are doing work in this area. And so I've really been excited to see kind of internationally what's happening.
I completely agree with you. So I mentioned before, I do some work with the European Association of Hospital Pharmacists. The Congress in the last 3 years, there's always been something on prescribing cascades. People internationally are really interested in this from a research point of view, but also from a practical clinical point of view as well. And as you say, without having that, if you like, pointy-headed academic approach to agreeing what a cascade is in the first place, you've got no chance in generating the evidence and the research on that. So yes, for some people it might be a bit boring and a bit sort of really good. But you have to do that if you're going to get organisations like NICE to recognise it and write guidelines on this. So it's really important work, Lisa. So just in terms of just to finish off, then what's next for you? What's on your agenda for the next 6 months or year?
Oh my goodness. Okay. Well, I was trying to think about that in terms of so deprescribing.org keeps me quite busy in terms of us making tools and resources to help inform, stopping or reducing medicines. That is guidelines, but it's also other tools and resources that we're kind of less well known internationally for, but we do a lot of work around how do we support people to make shared decisions with their prescribers, which I know you'll care a lot about, as well as we have a new tool coming around how do we help particularly primary care providers in Canada to optimize or pursue medication appropriateness. So we've got a new toolkit that's coming out in partnership with Canada Drug Agency around that. In terms of our guideline work, we are almost ready to release our newest statin guideline. And that'll be interesting in terms of how it's received, because again, shared decision making is at the core concept of how you're going to approach statin deprescribing. And so people maybe, we do a lot of work in terms of testing our messages. So we use the evidence-based approach to create our guidelines. We test our messages, and we test our most famous tools are our algorithms, those 2-pagers that we have. And we test those in practice with people to make sure that we've got them right. And people said to us in our user testing, I'm not deprescribing maybe as much as I thought. I'm having more conversations. Well, that's what we want to achieve. We're also updating our anti-hyperglycemic guideline right now, which is important because that was developed. There's been so much in terms of the advances of therapeutics and diabetes over the last year. So we're rapidly working on that one, and continuing our partnerships on other guidelines around diuretics, beta blockers, those kinds of topics. As part of that, we keep studying the implementation of guidelines. So I have a line of work where we're looking at how do we optimize diabetes in care homes in Canada. And then in the really near future is ICOD. So ICOD 3, April 27th to 29th in Montreal. And as I mentioned, that one's co-hosted by the Canadian Medication Appropriateness and De-prescribing Network, or CADEN, and ASTEN, or the US De-prescribing Research Network. That conference will be focused on deprescribing for the core people that have always attended, but also we're going to try and expand to medication appropriateness and optimization. And that's consistent with kind of CADEN's mandate, but we're also looking to try and do more work around involving policymakers and having public partners at the table for that. So if anyone is interested, the call for abstracts, the information is on the CADEN website right now, so you can kind of start planning. The call for abstracts will open in September, and the deadline is October 15th. So thank you for letting me plug ICOD as part of this, but I really hope to see lots of people there. It'll be really an exciting time.
Yeah, is it can you attend virtually or is it just in person in Montreal?
I believe we are, so we've been exploring, so I'm part of the scientific planning committee, but not the ultimate decider
Yeah.
on that one. We have been looking at options. I think it's going to be primarily an in-person event at this point, mostly due to costs.
I think the previous ones have been a bit of a hybrid affair where most people have been in the room, but there has been opportunity for people to join virtually. I mean, I'd love to go to Montreal if you want me to come and speak for you. I'd be very happy to do that.
Absolutely. Let's talk to the deciders on that one, to
Brilliant.
see if we can do that.
Lisa, I mean, the one thing that struck me there about the stuff that you're involved with in the future and ongoing is testing the messages and how well people use the guidance and where the struggles are with the implementation. Again, that's something that's often overlooked by guideline producers. It's they come up with beautifully constructed guidelines and have no idea how people actually struggle with using them in practice, and that's really really important for people.
Guidelines are only useful if people actually use them. And so nothing's, like they're only as good as the paper they're written on, is what we say often.
Yeah,
And so a lot of the work that I do has been looking at, like, how do we bring this evidence to practice, back to the kind of core of what I care about. And that does involve co-developing, particularly like our knowledge translation materials, our mobilization, whatever you want to call it, with in partnership with people that are to use them. So when we have an algorithm for clinicians, it has been co-developed and co-designed with a number of people in practice settings. Our patient materials, our public materials, we're also doing a lot more work in terms of how do we co-develop those. This is where it takes a long time, because people are always like, you've been working on that guideline for for a while. And we're like, yeah, it takes a long time to do that testing. But by the time we release it to people, we want them to have the confidence that we've done that work so that it can actually be useful in practice. And then we also know we've got a lot of work to do in terms of helping people to use them once they're released. And so there'll be a lot of work I have to do in the next. Wade Thompson is my partner in deprescribing.org, and our team have to do in terms of raising awareness about the existence of our newest guidelines and how do you bring those to practice. So lots of exciting times, but lots of work to do, which is great.
yeah. The production guideline does not end with the publication of the guideline. In
No.
some ways, it just starts there. It's how, as you say, it's how it's used and understanding how people use it in practice. That's the key thing. Lisa, that's been absolutely brilliant. Really, really great to talk to you. Great to find out about the work in Canada, internationally. We'll put the links in the show notes, as we said. If people want to go and try and submit a poster for ICORD, now's the time to do that, guys. So yeah, thanks very much, Lisa, and yeah, see you again soon, hope.
Yeah, any time, and hopefully not in a lift.
Yes,
But perhaps in a lift, but not a stuck lift, right?
indeed. Okay, nice one.
You can
Thanks,
make
Lisa.
friends everywhere, though. That's what's great. Thank you.
Thanks, Lisa. See you guys. Bye.
Bye.